Dr. Rosenberg, I'm so very happy to meet you.
My pleasure.
I'm
nice to meet you as
Ilise,
well.
thank you, Zimmerman, and I am the president and CEO of the Partnership for Maternal and Child Health. And we're very honored that you're granting us this time so that I can better learn and we can better educate both clinicians, but we also represent consumers. So I really need to share the information that you have about alternatives to opioids.
ALTO, Alternatives to Opioids. This is a program that my colleagues across the country are interested in learning more about, and this is something that I believe over a short period of time can spread nationwide as a new management tool to managing people who present with acute pain.
So I'm working in obstetrics and pediatrics, and you have a background in emergency medicine, but we're coming together because we both face women and children who are now suffering from addiction that theoretically could have been prevented had their providers known about your program.
You're exactly right. One thing we know is if you don't take opioids, you're not going to get addicted or dependent to them. So alternatives gives you an opportunity to manage pain without ever having the risk of addiction or dependency.
We're here to talk a little bit more about the opioid epidemic, and in particular how St. Joe's has had an outstanding program thanks to you. And I'd like to sort of roll this back because many of us, even myself, who is an avid reader and very interested in public health, don't really understand how did we get to this point?
This was actually the perfect storm. This was several bad things happening at the same time that just became a tornado. Let me explain. There was an article in the late 80s that came out in the Journal of Pain, written by a well-known pain specialist who said that opioids used for acute pain are safe and should be used without delay in any patient who presents with acute pain syndromes. After that came out, the Veterans Administration and the Joint Commission came out with a standard that everybody in healthcare needs to take the pain score as the fifth vital sign. At the same time, the drug companies who were making opioids were coming out with new versions of opioids that were stronger, more addicting, and longer acting. And even one more thing happened at the same time. The Mexican drug trade started opening up centers of black tar heroin distribution across the United States, first in San Francisco and eventually in every major city in the country.
In an effort to have patients minimally feel pain, in an effort to make patients feel better so that they can get through whatever the assault was, whatever the injury was, there was a backlash. There was another side to that.
Well, you know, it actually is worse than that. Let me explain. When the Joint Commission and the Veterans Administration came out with their new fifth vital sign standard, what they wanted to do is get everybody to a 0 pain score.
Wow.
So your ankle still hurts. Does that mean you need opioids? Well, based on that standard, many physicians went ahead and gave opioids when they were not necessarily indicated. You know, what's interesting is pain is a natural occurrence. It is our survival instinct. It happens to all of us, and it's important to realize that pain is good. It's not good if it causes you to lose function or inhibits the way you manage and do your normal activities. And I don't mean walking on crutches. That's how you alleviate the pain. So if you can't walk real well because of a sore ankle, you use crutches. But there has been a change in how society and medical community thought about pain, and they thought the idea was, let's get you to 0. So what medicines do I have in my medicine chest? What do I have in my drug box? What weapons do I have for me? And you know, initially the physicians would look in that toolbox and they would see they had Tylenol, or a medication, acetaminophen. They may have had Motrin, and they had opioids. And if I had to get you to a 0 pain score,
Sure.
I'd go for the opioids. I was told they're not addicting. I was told that they're safe, and they're the strongest pain reliever I have. That's how we got here.
One of the wonderful things about St. Joe's is that it has taken a stand and become a role model for other hospitals in looking for alternatives. In fact, I think that ALTO is the acronym, right?
That's correct, yes.
Alternatives to opioids. So how is it that you came up with this concept and have become such a strong leader in this field of decreasing the epidemic?
And we had 2 goals. One, we wanted to become the leading expert in managing acute pain in the country.
Okay.
And opioids is not the standard to treat acute pain.
I see.
It covers up the pain. Our goal was to actually use targeted therapy that actually stops the pain, stops the pain receptor, so that you no longer have the severe pain that you had. And also, part of our goal was, if I don't give you opioids, you will not get addicted. You know, it's interesting when I lecture to a large number of people, and I always ask the question first, how many of you want to become addicted? And everybody says, nobody raises their hand.
Of course.
So the goal is not to become addicted, the goal is to be functional and manage the pain so that you can still function. So our goal was to develop these protocols for the 5 most common conditions that come into the emergency department. These are evidence-based protocols using targeted therapy, and I don't want to make it too scientific. Bottom line is we manage pain with the ALTO protocols better than managing pain with opioids.
Wow.
Safer, non-addicting, do not cause dependency or addiction, and work extremely well.
So what are those 5 reasons that individuals come to the emergency room for assistance in decreasing pain?
So we're looking at headaches, including migraine headaches. We're looking at back pain, musculoskeletal pain, fractures, and sciatica.
Okay.
So if we look at all those pieces, we have treatment protocols for each one of those diagnoses that does not use opioids. Now, it's important to know, if we need opioids, we will use them.
Understood.
Can I give you an example?
Please.
If a patient's involved in a traumatic car accident, or if they're run over by a car and they have a severe pelvic fracture, that person needs opioids.
I see.
But somebody who comes in and they sprain their ankle playing soccer, they don't need opioids. They may need a lidocaine patch. They may need a layering of different therapies that actually improve their function and alleviate their pain.
So the philosophy that you've brought to the St. Joe's ER, has that permeated surgery and anesthesiology yet?
You know, it's very interesting. I had a report last night from the chairman of OBGYN, who reported by using ALTO principles for his patients, 2 different patients populations they looked at, those who had C-sections and those who had major abdominal surgery. On both of those cases, he was able to decrease opioid use by more than 50%. So we took the ALTO protocols and we met with each of the chairmen of the various departments in the hospital and challenged them to come up with their own protocols for their common diagnoses and common complaints and see if they can beat us. So it's a little bit of a competition. And Dr. Kearse is our chairman of OBGYN and has done a phenomenal job. There's another point here that I think is very important. How do we get the physician community to buy in?
Okay.
And what's so fascinating is every one of the physicians who are part of the emergency department and part of the OBGYN department are hungry to use other protocols to manage pain that don't cause addiction or dependency.
So they're looking to you
Exactly.
for advice and guidance and suggestions.
Exactly right. They're looking to us to see if we can help them come up with protocols that make sense, or they're using our protocols and principles. In the emergency department, as I said, the toolbox only had Tylenol, Motrin, and Percocet in it, for instance. What we did with ALTO is we put more tools in the toolbox, more pain management options, more technique to manage pain. And the physicians were hungry for it. And as a result, every physician in my department bought into the ALTO principles right away.
How about the consumer? How about a person who comes in and they know that when their back hurt before, they got Percocet and it went away. Now you're coming in and you're saying, I have an alternative. Has the patient acceptance mirrored the physician acceptance?
It is a perfect question. And I go back to when I lecture to 500 people and I ask everybody in the room who wants to become addicted, and nobody raises their hand. If I can treat you with a safer alternative that has no risk of addiction or dependency, and you respond nicely, I'll do it right here, and you'll respond better, and you'll say, I'm feeling great, doc, thank you. Let me give you an example.
Okay.
That person with back pain, instead of me giving them Percocet, which I too would have given 5 years ago, now I'll give them a trigger point injection, maybe put a lidocaine patch on their back, give them some medication that's non-addicting and evidence-based, and immediately they're feeling better. They don't need any more, and they're happy with that.
Wow.
We've seen 2 groups of patients increase, actually 3, since we started the ALTO protocol. Number 1 is young kids. Kids who are on the soccer field, they sprain their ankle, they fall and they get hurt, or even have a fracture. Moms are bringing them in here instead of other hospitals because they don't want their child to be exposed to opioids. Obviously, that makes a lot of sense. We've also had people bring in their mom or their grandparent who may have fallen, may have a hip fracture, and they don't want them also to have opioids. In the elderly, opioids can cause dizziness, increased falls risk, constipation, lots of complications. So we're seeing that group. And a third group we're seeing more of, and those who are previously addicted or dependent on opioids or alcohol don't want to go down that pathway again. So they're coming here to have opioid-free management of their pain. Opioid addiction, there is basically 2 pathways. So if we look at the inner city and the poorer socially economically stressed areas, what we're seeing is the pathway into opioid addiction tends to be by street drugs or heroin or fentanyl, and that's the pathway. When we look at the suburbs, we're seeing more from the prescription side. Both end up at heroin. And let's look at the cost piece. If you are dependent on oxycodone, if you're dependent on Percocet, and you can't get the prescription any longer because your doctor won't give it, the emergency departments aren't giving it to you anymore, you can buy that on the street pretty easily, but it may cost you $30, $40 per pill. And that cost is okay maybe for a short period of time, but eventually it's too costly. Heroin, maybe $2 a bag, so it's readily available. It's easy to find, and so the folks in the suburbs, the children in the suburbs are so at risk for exposure to opioids. And there's one major reason why. Opioids alleviate or get rid of social anxiety, social awkwardness. So I see young kids, particularly in the age 13, 14, maybe get exposed to opioids from their dentist for the first time.
Okay.
And then maybe they go to a party that evening after they had their wisdom tooth taken out and they're taking some Percocet. And all their friends acknowledge the fact that, my goodness, you're the life of the party tonight. And that child right away knows that the opioid, it made them less socially awkward. That is an immediate psychological dependency.
Wow. So parents need to understand that there are alternatives when in fact you come out of the dentist. They may have to educate their dentist to look into your program.
Absolutely right. And not only that, a little bit of pain is not bad. You know, it'll tell you not to chew on that side. It'll tell you different things if you just went to the dentist. So you don't have to treat every bit of pain. And also we can use other remedies that my grandma would use. You can put some ice on your jaw. You can drink some cold beverages that'll actually help with the pain. You can use lidocaine patches. The dentist frequently will give a long-acting injection of a medication that'll numb up the mouth. But these are other ways to manage it. And Tylenol is a great drug. I do want to give you a little hint though.
Okay.
Tylenol works great. Motrin works great. But you put the two together and it's much more powerful than either one alone. There's a scientific reason for that, but the real key is combining medications that are safe to combine together will actually improve the pain relief and sometimes be stronger than morphine.
That's fantastic. And I think that that's the kind of message that consumers such as myself, who are not clinically educated, need to know, that there's not a magic bullet for pain. As you said, a certain amount, if it's not debilitating, is okay. And secondly, that they should check with their provider. If the provider is not a part of the ALTO program, that they could look into it.
If I can give you one last statistic.
Of course.
The Center for Disease Control gave a report of patients who take 5-day therapy on opioids.
Okay.
6% of those went on to long-term opioid use and dependency.
Okay.
That's not insignificant. So when we think about it's only 5 days worth, I can take that, it's safe. 5 days worth of opioids can be the difference between not being dependent and being dependent. So these drugs are excellent, but the opioid drugs are excellent, but need to be used with respect and in the right clinical circumstances where they're beneficial to the patient and the benefit outweighs the risk.
If I am the mom of a child who's been hurt on the basketball court, and I bring my child to the nearest urgent center or emergency room, and the physician there suggests that that child go on Percocet or an equivalent, as an organization that tries to empower mothers and children, how can the mom respectfully address that physician without being challenging, but also recognizing that she doesn't want her child to become addicted?
You know, we're in an age of internet and easy access to information. There's websites where you can find out what's wrong with you, and they're actually very, very good. There's ads on television all the time for different medications that the drug company wants you to ask your doctor, is this medication correct for me?
Okay.
Well, consider ALTO, alternatives to opioids, as one of those public service announcements. We all know that opioids are dangerous, they're risk of addiction, we don't want our children to be exposed to them. So I don't think, as a physician, I would be offended if anybody said to me, hey doc, I prefer you try an alternative first. I'd rather my son not be exposed to opioids. Okay. And I think that's a fair approach, and I think every doctor would give you an appropriate answer, a professional answer. Either they can, and maybe they can't. I'd like to say one other thing about opioids.
Of course.
Opioids are extremely good medications when used appropriately.
I see.
Using them for an ankle injury or a back spasm is not the appropriate use of opioids. But if you have cancer pain, if you have fibromyalgia, if you have a bad fracture, if you have bone mets from cancer where it's spread to the bones, these are indications to use opioids because they work extremely well. So I don't want everybody to be afraid of opioids if they're needed, but I want to recommend taking alternatives first and seeing if that would work. And if it does, it would either you won't need opioids, and if you do, you may need a lower dose. That would be helpful.
That's a great response, and I appreciate your time so very much. Thank you.
My pleasure. Thank you.
Good to see you.